All right, welcome back. I'm Saqib Rahman from Temple University Hospital. I'm going on to the second part of our lecture on fracture healing and repair. And just to recap, in the first portion we went through the basic bone biology, stages of fracture repair, what you need for fractures to heal, such as extracellular matrix, cells, vascular supply, bone growth factors, and few things about when fractures don't heal or when you have some abnormalities and how we can treat them. And now we're going to talk more about clinical aspects. So any clinical evaluation starts with a history, and typically fractures are going to be traumatic, so you have to elicit some history that there was an injury or fall or something like that. It could be atraumatic. So for instance, if you have a bone tumor, that's one example, where the bone itself is abnormal and gives way without any obvious trauma or stress to the bone. Typically there's going to be pain, all right? So when you're assessing someone and you're worried about a fracture and they don't really have pain, then they probably don't have a fracture, unless they don't have pain for some reason, like they're paralyzed. They may say they heard a crack. They're usually going to have some type of immediate disability, especially if it's a displaced fracture. So on inspection, so now you go on to a physical examination, inspection, you want to look for deformity, swelling, ecchymosis. I mean, it's not always this obvious where there's an open wound and maybe you see a bone coming through or something, but certainly these are some of the things you want to look for. And certainly palpation, this is really critical, okay? So with displaced, grossly angulated, unstable fractures, I mean, you may not even have to do this in every case and say, hey, there's a hurt here where someone's bone is coming through the skin. So, but if you have somebody who twisted their ankle and you're not sure, you want to make sure that do they have tenderness at the fracture site, right on the bone. So for instance, for the ankle, if they have tenderness over the ligaments but not really on the bone, well then maybe it's an ankle sprain. Okay, so when in orthopedic examinations, the findings are very somatic, or pain is somatic. So it's not, for instance, like when somebody's having a heart attack and you can't just put a finger right on their chest, right over where the myocardial infarction is happening and say, well, does it hurt right there? No, they say, you know, I feel like there's a weight or a crushing feeling, or your arm starts to hurt, or, you know, no. When you have a fracture, you can point right to exactly where the pain is, almost with a finger. That's very important for clinical exam purposes. You want to look for instability. You want to see if there's painful range of motion, if it's near a joint, for instance, and maybe you want to check for pulses. Not maybe, you should, but maybe there's an impaired pulse, I should say. You want to do a detailed neurologic examination where you check for sensation, reflexes, muscle tone, motor exam. We'll certainly get to that and why that's important. So going on with your evaluation, you want to look at imaging, right? So fractures, you want an x-ray, right? So plain radiographs are usually sufficient, especially for long bones like this. You want 90-90 views, so you want, like, for instance, an AP and a lateral, for instance, in an extremity like this. You want to make sure you see a joint above and joint below, and I won't get too much into that, but if you rotate with us clinically, you'll see the importance of that. Sometimes you need a CT scan. So CT scans are like x-rays, and they're very good for looking at bone. You don't always need it, so you probably don't need it for this, but you do need it if there's a fracture going into a joint. And some bones that are just not as easily imaged with two-dimensional x-rays, like the pelvis or maybe the scapula. And it can be helpful for preoperative planning. And sometimes you actually need an MRI or nuclear imaging like a bone scan, in order to find an occult fracture. So something you don't even see on x-ray, but you're really convinced that there's a fracture. Maybe because they have point tenderness right on that spot. So what about treatment? Well, bone heals itself by regenerating new bone tissue rather than healing with scar tissue. So if you think about other organs or tissues, skin for instance, when you cut yourself, you get a scar. Or when you lacerate your I don't know, muscle tissue, or we talked about a heart attack before. I mean, when you get you get fibrosis, you get scar tissue, all right? So it's not really new tissue that organ had before. It's now scar tissue. But bone, if it healed with scar tissue, you'd never be able to restore stability and function again. So the body obviously has a mechanism to make new bone. Now we can assist it in optimizing fracture alignment, what we call reduction, articular alignment, length, rotation, and we can also help optimize the local environment perhaps. And those treatment options are closed reduction and casting, as shown here. Open reduction internal fixation, shown here, like a plate and screw type device. You don't see the screws here, but this is an example of a metal plate that we may put on the surface of the bone and then put screws through it. External fixation, shown here. This is for instance, a tibia where you have pins, and this is a device where the device actually is outside the skin. Okay, it's external fixation. And then you have something like intramedullary rodding. So for instance, instead of treating whether this, let's say a patient had a tibia fracture, instead of treating in a cast, you actually take this rod and go inside, intramedullary, so it's inside the medullary canal. And sometimes you have to do arthroplasty or replacement, and that's typically for a fractured articular surface. For instance, the femoral head is a good example, or humeral head, and you'd have to do a partial joint replacement or a full joint replacement. So casting is indicated when fracture alignment is an acceptable alignment. Okay, and you may use plaster. Here you have a splint, but this can also be a cast like shown in the last photograph. Open reduction internal fixation is when you do a surgery and go in, or you open, and reduction means you put the pieces back in place, and internal fixation. And this is something that is done when near anatomic or anatomic reduction, meaning putting something together perfectly, a fracture alignment is necessary to restore function. And this is something that on certain bones is necessary, certainly articular fractures. Other fractures that's done very commonly would be like the forearm. It's often done in the humeral diaphysis. And here's an example in the scaphoid, for instance. External fixation is indicated when fracture is in acceptable alignment, and or maybe the limb's condition is not amenable to open surgical intervention. So let's take, for example, this patient had this elbow fracture dislocation, and it was an open wound, and there was a vascular injury, and you have to go to OR immediately, but you really are not equipped, prepared, or you don't feel the patient's ready necessarily to do this reconstruction of the articular surfaces, so you can do a temporizing external fixator. And sometimes an external fixator can be definitive management. We're not going to get into all the nuances of this, but just so you know what the devices are, for instance. Intramedullary rodding is indicated when only gross fracture alignment is necessary to restore function. So you don't need to get things perfectly, but for instance, in the diaphysis in the lower extremity, so in the tibia and femur, this is a very common technique and tends to work very well, whereas in the upper extremities we tend to do open reduction, internal fixation, and with plate and screws more often. But I mean, this is an incredibly successful technique for fractures in the femur, for instance. And arthroplasty can be done when articular fractures are not salvageable. This is maybe not the best example, but let's just say you had a fracture in the radial head where this piece was off and there was another piece off here, and the neck was fractured and the whole joint was unstable, so you had to provide some immediate stability. Well, that's where you can just throw this in the trash. Essentially, this goes out and then you replace it with this metal head with a little stem that goes inside. And you can imagine the femoral head, for instance. It's probably the most common place you see this done, where people get hip replacement, sometimes for certain fractures. Associated neurovascular injury. So remember, fractures don't occur in isolation, okay? And some people even say that a fracture is a soft tissue injury with a broken bone. So just to kind of relay the importance of that. And it's important to know that neurovascular injury is not always obvious. And I have to say, I mean, I really don't like it when people say neurovascularly intact. It really implies that everything's intact and you've checked everything. It's always better to document what you saw, what actually was working or not working. So it requires careful and repeated examination because these things can change over time. Someone may have a pulse when they come in and now they don't have a pulse, or someone radial nerve was working, or their sciatic nerve was working, and now it's not working. Associated neurovascular injury, this is important also because it can potentially lead to limb-threatening problems. So if you have a vascular injury, certainly somebody could lose their limb from this. Keep in mind, nerve injury requires patient cooperation. So if you have an intubated patient or a patient who's unable to communicate for whatever reason, they just had a stroke, you can't, or maybe a stroke's not a great example, but they're comatose for some reason. You may not be able to get a good nerve assessment. And compartment syndrome, I'm going to go over shortly, and this is something you absolutely don't want to miss. Vascular injuries can occur from penetrating or blunt trauma. They require immediate diagnosis and treatment. So here you have an example of somebody with some open distal femur fracture, and you can see the popliteal artery kind of come to a halt right about here, and just it stops. You got some collateral circulation, but that's a problem. Tissue death can occur within hours with warm ischemia, and it requires early involvement by a vascular surgeon. As I mentioned, neurologic injury requires a cooperative patient. It needs very careful and repeated exam. You could have different stages of nerve injury where you have either a neuropraxia with just sensory deficits, or axonotmesis with sensory and motor deficits, where surgery might be needed. Neurotmesis, which is when you just have the nerve severed essentially, and in those cases there's no continuity and it will require surgery. So compartment syndrome, I kind of mentioned this is really important, you don't want to miss it. This is basically when you have increased intracompartmental pressure. So this is something that's seen often in the lower leg. It's also seen in the forearm. These are just two of the areas where it happens the most, but it can also happen in the thigh. It can also happen in the gluteal muscles, in the upper arm. But common locations are the lower leg and the forearm. So it's due to fracture or some kind of severe soft tissue injury causes this increased pressure. And when I say compartments, you're talking about the fascial compartments in the extremity, okay, that have these sort of tight confines. It can be due to prolonged pressure or prolonged hypoperfusion to the limb. So if somebody has a vascular injury, they're not perfusing their limb, they can get a compartment syndrome. Or somebody who's been in an earthquake and something's laying on top of their leg, crush injury, that can lead to compartment syndrome. And this is a tissue ischemia that can lead to muscle death, all right, and it's a surgical emergency, all right, and this is very important. If you make a diagnosis, it requires an immediate fasciotomy procedure like is shown here in this picture in the operating room. So the clinical signs are the so-called 5 Ps of pain, okay, especially pain with passive range of motion and pain out of proportion to what you would normally expect. Paresthesias, paralysis, pallor, pulselessness, okay? And you can't measure most of these in an obtunded and intubated patient or somebody who you can't communicate with, for instance, somebody with a psychiatric problem. You also have to be very careful with someone who has a different language or culture where perhaps their pain is being expressed differently, or maybe they're more stoic and they don't speak your language. So, and in children, sometimes they can't communicate this well and they just seem anxious. You can get some objective findings with compartment pressure measurements. So if you have pressures greater than 30, that could possibly be a compartment syndrome, but a more reliable finding is a delta P, or so-called diastolic pressure minus compartment pressure of less than 30 millimeters mercury. And to get these pressure measurements, you literally have to stick a device into the compartment. And we have these special devices with a needle that goes in and checks the pressure. So as I said, these most commonly occur in the leg and forearm. They can also occur in the thigh, foot, arm, hand, buttock. Patient who's found down, and we use that term when we find patients who have drug overdoses or alcohol intoxication, and they're just laying down for hours and hours in an awkward position in a surgical emergency. Misdiagnosis can lead to permanent muscle death, contractures, and lawsuits. So we'll wrap up by talking a little bit about fractured nonunions. So we talked all about this stuff about how fractures occur, how they heal, and now we'll talk a little bit about when they don't heal. And this can occur essentially when a fracture doesn't heal, and the patient will have pain. They'll have persistent pain. So they still have pain at that fracture site months and months later. There may be tenderness directly over the fracture nonunion site. You may see a persistent fracture line, as is shown here. You still have this line. In fact, in this case, the line has extended beyond where you would think is the normal outline of bone, and it's even extended out into here, right? And remember, what's needed for fracture healing? Cells, extracellular matrix, blood supply, molecules and growth factors, and mechanical stability, right? So if anything goes wrong with any of these things here, you can potentially get a nonunion, okay? So an atrophic nonunion, these are some terms you should be familiar with, is when you have a lack of any of those things, for instance, lack of the biologic requirements. Okay, so just not making bone because you don't have cells, you don't have extracellular matrix, you don't have blood supply, or combination of those things. And it needs what's called bone grafting. So we often have to take bone and transplant it maybe from somewhere else in the body. The iliac crest in the pelvis, the femur medullary canal are two such sources that sometimes we use, but it can be obtained from many places in the body. This is that example I showed in the last slide where you can have a hypertrophic nonunion, and it's the biology's there. So in this case, you can see it's this little lump out here is some evidence, and over here the body's trying to make bone, but it just can't bridge across here because there's so much motion the fracture can't stabilize itself and heal. So it just needs better stability. So it may not need bone graft, it just needs something to hold that from moving until it has a chance for this bone to just kind of bridge across. Okay? If you have a lack of extracellular matrix, like this fracture here, you have this massive, massive gap, right? And sometimes just large defects like that won't heal. There's nothing to heal onto. You don't have that sort of structure for cells and growth factors to get started. So here you can perform bone grafting to provide that scaffold, an osteoconductive scaffold is the term we use for bone to grow onto. Now, you can also have a lack of growth factors. This one's a little bit hard to diagnose sometimes. This could be a case where that's happening. Growth factors can be administered to a fracture nonunion as a form of treatment. When you bone graft somebody, you're getting some of those growth factors, but these are also some commercially available products we can use. Or poor vascular supply. Now, this can occur in smokers, diabetics. Sometimes you may need to bring vascularized bone to help this to heal, and sometimes you need to reestablish. You can see this, this cortex coming down, and then it's kind of sclerosed off here, and then here you can see that you're not getting this medullary blood supply. So if you sort of open this up, you can allow the intramedullary blood supply to be restored. And one other thing is infection. Infection can also prevent a fracture from healing. And lack of mechanical stability. So this is not really a biologic factor so much, it's more of a mechanical factor. And here's where you can get, for instance, another hypertrophic nonunion. So you can see lots of bone, being made, all this extra bone out here, this irregular appearance. But you can see that this crack just hasn't gone away. The patient still has pain. So the biology is there, but the bone just can't bridge across that fracture site due to motion. So it needs to be stabilized. You go in and just stabilize this, and doesn't need bone graft, and you can often get that to heal. So, brings us to the end, and just to recap again, our lecture objectives were to understand the proper assessment of fractures, which we covered a little bit more in this half of the lecture, understand the basic management of fractures, which we talked about also. Understand why some fractures don't heal, and if you understood everything in the first lecture on the basics and basics of fracture healing, and then we talked about nonunions at the end of this, hopefully that links it together, and now you can understand why some fractures don't heal. And then to understand complications and associated injuries, we talked about some neurovascular injury, we talked about compartment syndrome, and you should be aware of those also. All right. Thank you very much. Please don't hesitate to contact me if you have questions. And if you're listening to this, you know that this is on the OrthoClips.com website. And this is also at if you go on YouTube and you type in OrthoClips as a search, it's got to be one word. And if you click on it, it might default to 2 words, and where you won't find this. But if you redirect it to OrthoClips, you'll see there's a channel where there's tons of these instructional videos, and enjoy. Thanks.